Hello, welcome to the RN FIM Training Seminar at Memorial, and I'm going to share with you some information today about the rehabilitation unit. It's an IRF facility, which stands for Inpatient Rehabilitation Facility. So if you hear the term IRF, it is the same thing as the rehab unit. We're going to discuss FIM scores today for bowel and bladder function and management. FIM stands for Functional Independence Measure. Now we have the Functional Independence Measure, or FIM, for all levels of assistance and tasks that a patient performs for their activities of daily living, or their ADLs. But we're going to focus specifically on the bowel and bladder function and how to score that as a registered nurse. And I think you'll have a better understanding of that after this seminar. I'm glad you're here. Please fill out the pre-test that was sent to your email as you arrived. You can fill that out on the tablet that was provided to you. At the end of our seminar today, we will have a post-test that will be sent to your email, and please fill that out and return it to the instructor at the end of the seminar. Just to give you a little background, my name's Jackie. I've been in nursing and healthcare for a very long time. I've been a nurse since 1993, and I really do enjoy the rehabilitation department and what we do on the rehabilitation unit. It's nice to see a patient go from needing quite a bit of assistance when they arrive on the rehabilitation unit, and then gaining independence in a short amount of time, 10 to 14 days that they're on a rehab unit. And physical therapy, occupational therapy, speech therapy, and nursing all participate in an interdisciplinary plan of care or team meeting every week to help determine the best care for each individual patient. So I'm glad you're here. It's exciting to be on the rehab unit. And just to give you an idea of some of the things that really help me out and the things I've enjoyed about rehab, one of the best patient experiences that over my nursing career was a patient who was only 34 years old. He was a male. He was married. He had two very young children. He was an engineer and worked at a very large company, Caterpillar, and he had a stroke. He came to the rehab unit 3 days after his stroke. He wasn't able to eat. He had tube feedings. He had IV fluids, he had a Foley catheter, and he wasn't able to communicate to us. He couldn't tell us what his needs were. His right side was almost completely useless. We watched this gentleman work hard with therapy and with nursing to go from very little function when he arrived on the unit to being not fully independent, but almost fully independent when he left our unit. So he came back to our rehab unit 1 year after he had had a stroke to let us know that he was doing great. He had regained all of his function. A little bit of lag was left in his right leg when he walked, but not much. If you weren't looking for it, you wouldn't have noticed it. So he came back to thank us for all the care that we provided him and the encouragement and the teaching that we provided to him. So that's probably one of the best experiences. One of the more difficult experiences, nursing anywhere isn't all great every day, all the time, but you can still pick out those important and special moments. There's going to be a time when some patient touches you, and it might not be that they had the best experience on the rehab unit based on functional independence, but you know that you made a difference, and those are important as well. Not everybody coming to us is going to leave fully functioning. They may have a long road to go before they get back to fully functioning if they're able to. So one of the more difficult scenarios that a patient that I took care of was a young man who was only 20 years old. He was in a farming accident when he was working with his dad, and he was from a small farming community. He was the oldest of 4 kids, and he was only 20, just starting his life, traumatic brain injury, and he didn't recover. He didn't gain his independence. He still was incontinent of urine, incontinent of bowels, and unable to walk, unable to feed himself when he left the unit. The blessing, in my opinion, was being present to the family and the extended family, and helping them to learn how to care for him, and helping them to acknowledge that he might advance and improve, but he might not, and to love him where he is at. That was tough. That was a difficult experience, but still very, very rewarding as a nurse. So I want to share a Bible verse with you. James 3:13. It says, "Who is wise and has understanding among you? He should show his works by good conduct and wisdom's gentleness." When we talk about bowel and bladder function, it's normal, I think, for nurses to discuss bowels and bladders and fluids that come out of every different place of the body, and we don't typically, we lose our sensor to that kind of thing, I think. At least I have. So patients who come to our unit, we might be asking them, did you have a bowel movement today? Are you able to urinate? Can you pee? That might be a little too abrasive or aggressive for some patients. So just temper the information that we need to obtain, and then also the information and the teaching that we do with the patient, temper it with that compassion and kindness. And remember, this isn't a healthcare worker. This is someone who is a patient, has privacy, and might not fully be able to discuss their bowel and bladder function in an offhand way like nursing can discuss that, or healthcare professionals can discuss that. So build rapport with your patients and have compassion and kindness. And when they're not always offering information, just remember it's probably not their normal conversation around the dinner table. So with that, we're going to move on to what we want to learn today. What is it about the bowel and bladder FIMs that we need to know as nurses? Well, first of all, I want you to know when you leave today and you go back to your unit, you're FIM-tastic RNs. Know that, own that. Today's training, we're going to talk about how to utilize the FIM accurately, how to score it accurately, and I've got some great tools for you to use and look through. And your best friend will be the electronic chart. It has all of the information that we're going to discuss in drop-down boxes, and you click whatever your patient required for assistance and however independent they were or how much assistance they needed, and the computer tabulates the score for you. So that's a great advantage to computerized charting as far as I'm concerned. And then also how to use that information. You need to know what the numbers mean, because you need to be able to share that in the interdisciplinary team meetings. And also, how can you create the plan of care for the patient? What are the barriers to bowel and bladder management for this patient, for each individual patient? So you'll be putting your brain cap on and be a little bit brainy today when we're talking, and a little bit of lecture with certain material, and you're going to read through the handouts as we're going through that. And then also we're going to play a game, and that game is to help us think about what are those issues, what are the ways we can address those issues for this type of patient, what are the things to look for, and what are the interventions to promote and to follow and to put in the plan of care and share with the interdisciplinary team. So we'll play that game in a little bit. And then also I want you to realize, as a registered professional nurse, what you bring to the table at the interdisciplinary care team meeting is important. It's valuable information. You are with the patient 24/7. Nurses are. So what we bring to that meeting is very important. Know that. Share information with your team members and let them know what's going on with the patient, what the patient said to you or to another nurse, and how they're feeling about their stay at the hospital and what they're learning and what they want to achieve. Those are all very important and valuable pieces of information. Remember that and share in the meetings. The team wants to know what's going on with you and the patient. So CMS guidelines for bladder management. CMS is the Centers for Medicare and Medicaid Services, and they have guidelines that IRF facilities follow. IRF stands for Inpatient Rehabilitation Facility. So we're an IRF. I call us rehab. A lot of people call us rehab. So these two forms, they're in your handouts, and they basically give you a breakdown of the scoring system that CMS has developed for us to follow, and it shares how well the patient was doing and how independent they were. The score is important, especially in the time frame where they arrive to our unit, meaning that's going to show probably how much assistance they required. So less independent, required more assistance, and by the end of their rehab stay, it should show a pretty significant increase in their independence and their functional ability. So that's why the score is important for us. It lets us know that we're helping the patient to progress along a certain path, and also lets CMS know that we're doing that same thing. CMS is very involved in IRFs and long-term care and getting patients better. So the bladder management scores and the bowel management scores are the same. And I'm going to just show you, before we go into those scores, what the documentation looks like in the chart, but printed out in paper form. So all of these are instances where you can click a drop-down box, select whatever your patient required, whatever assistance they required for each section, and when you fill that out, the computer tabulates the score for you. So you don't have to try and think about, well, are they this number or are they this number? The computer will automatically give us that score. But it's important, again, to know what those scores mean. The drop-down boxes help us to score accurately, so be aware of that. And the associated level or score is going to be in parentheses behind these different drop-down boxes, so you know approximately where you're at in their scoring and how the patient is improving or maybe not improving. And then patients probably going to be lower scores when they first arrive to the rehab unit and then gradually increase. Not everyone is going to leave at a very independent level, though. Some people might need more time to achieve and attain that independence that we hope that they gain in the future. The CMS guidelines for bowel management. So again, these 2 pages are in your handouts, and you've been using these scores now with your preceptor for at least a month and discussing that. And 7, I'm sure you've already been told and are aware that 7 means independent. That means they're able to complete their bowel and bladder management tasks independently. They don't have any assistive devices, and they don't require any assistance from a helper. And CMS calls nurses, techs, anyone helping the patient or assisting the patient, they term that person the helper. So when you hear me refer to the helper, that's why. So 6 on the scale, according to the CMS guidelines. 6 means that the patient is mostly independent, but it's a little bit modified from complete independence. So that modifier is going to show up in your documentation, and the modifiers could be they needed an elevated toilet seat or they needed a medication, but we're still not putting hands-on assist or having a helper present with the patient. So 7 and 6 are independent, just depends on if they have a modifier for a 6th level. 5 and below. 5 starts where the helper is present. So 5, standby assist, means that just that. You're standing by, you're not providing hands-on care, you're there maybe for managing safety. If there's a concern that the patient may lean too far one way, or that there might be a safety concern and we want to have a staff member present for a safety measure, but they haven't needed to apply hands to assist the patient, that would be a standby assist. Another 5 would be a setup of assistance. So if the patient requires a urinal, but they can't go to the bathroom, get the urinal, bring it back to their bed, use the urinal, and then take it back to the bathroom to empty it, well, that's a setup assistance. That's the helper can place the urinal at the bedside, patient can use the urinal, then the staff or the helper takes the urinal and empties it. That's really setting them up to perform their bladder management tasks. So 4 is minimal assistance. That means we have hands-on assistance now. And 3 means that they need more than just a little bit of help. They need a moderate amount of help. And 2 means that they're maximum assistance, meaning the helper has performed most of the task for the patient. 1 means that's total assistance from the helper. The helper has completed the task for the patient. Now there is a 0. The 0 means that the activity did not occur. We don't typically score a 0. We're typically scoring this instance happened with this patient, and here's where they were at on this scale as far as their independence. So look through those. Myself, when I was on the unit, we had this form by each computer, and it was handy to go through that form. It's a yes/no drop-down boxes, kind of before drop-down boxes came out on computers. So if you start over on the one corner, it says, is the patient independent in their bowel and bladder function? And you say yes, then you go one way. If you say no, then you follow the diagram another way. So yes/no questions to the correct score. Look that over. I'll give you some great tips in there on what to consider. So FIM accuracy really does matter. We have the drop-down boxes with the numbers present, and your computer system scores the level for you now. And the lower the score, the more assistance is required by the patient. Not everyone is going to leave our unit as a really high score, just to let you know, because some people are going to require a longer amount of time to be able to achieve more independence. So game round 1, we're going to have 2 teams, so split up into 2 teams. Team 1, you're going to have stroke. Team 2, you're going to have spinal cord injury. And I'm going to put a board up for each team, and you're going to have a permanent marker to go right up on the board one at a time. You have to hand the marker off to each other, but write up something that impairs the ability to perform the bowel and bladder management independently because of the diagnosis that you're working on. So ready, set, go. So we're going to look at the CVA, and then we'll look at the spinal cord injury board in just a moment. But those of you working on the CVA or stroke board did a great job identifying factors that could influence and impede a person's ability to manage their bladder and bowel tasks and management program. So being disoriented, having cognitive dysfunctions, those all impact the ability to think through, do I need to go to the bathroom? Do I need to have a bowel movement? Do I need to urinate? Where is the bathroom? How do I get to the bathroom? How do I walk? Those are very realistic questions that a stroke patient may have. Weakness on the one side, hemiparesis, very true reality for stroke patients. They may not be able to functionally get to the bathroom to be able to use to manage their bowel and bladder program or their activity and tasks. Urinary urgency, bowel dysfunction, that could be going on prior to having had the stroke. So think about those issues that might be contributing to the stroke diagnosis itself. Speech impairment is a big one for stroke patients. If they can't tell you that they need to go to the bathroom, that's a big barrier to having success and being independent with their bowel and bladder functions. IV lines, tube feedings, Foley catheters, those are all lines that could prevent the patient from getting from point A to point B or to the bathroom independently. So getting rid of those lines as soon as possible, and maybe changing things around so that we don't have to have the lines during the daytime while they're on the rehab unit. Safety risk measures, someone who isn't cognitively aware that they need to have assistance when they get up to go to the bathroom, that's a big risk factor and impairment for someone to manage their bowel and bladder function, because we're telling them to get back in the bed or to sit down in the chair, and they're trying to get up, but they might not have the ability to tell us why they're trying to get up or what needs to happen. So excellent issues that contribute to bowel and bladder dysfunction for a stroke patient. So round 2, now you're going to take, same teams, take the markers, and in the same way you're going to come up with an intervention for those impairments that you identified. On your mark, get set, go. So for a stroke patient, you identified disorientation, and that's a great intervention to do hourly rounding and reorient the patient during the hourly rounding. Getting physical therapy and occupational therapy on board to do strengthening exercises for the weakness that's probably going to occur for a lot of stroke patients. A toileting schedule, getting the bowel and bladder management in order to by creating a schedule for the patient's body to become familiar with and to utilize. A picture board. Speech therapy is great at developing images and pictures and boards, and occupational therapy as well, for us to communicate and for the patient to communicate to us. Discontinue the Foley, the IV tubing, doing tube feedings at night or doing water boluses. Those are all great interventions to help decrease the barriers to gaining bowel and bladder function again. And the bed alarm, the chair alarm, the 4 Ps, the possessions, potty, position, and potty. Sorry about that. The 4 Ps, very important to have those things for our patients. Those are the 4 things that we know they're probably going to get up and try to get to or try to take care of. So having those present and available, check those out on your hourly rounding. And spinal cord injury team, great barriers identified, great interventions identified. So all of you have done some really critical thinking about what does impair this type of patient. How can we help this type of patient? What interventions can we bring to the table and put into the care plan, the plan of care, and bring to the interdisciplinary care team meetings to help this patient along? Something to think about is dexterity. For a spinal cord injury or a stroke patient, they might have impairment on their dominant hand side, and so maybe building dexterity with physical therapy and occupational therapy, and then teaching the patient how to perform a straight cath if that's required, or insert a suppository if that's required. So really working together with your teammates during the interdisciplinary plan of care team meetings. And learning outcomes. I think we talked about how to truly identify the accurate FIM measures. You've been looking at those with your orientation and with your preceptor, following those algorithms that are in your outlines and that we discussed, and then how to accurately score the FIM measure for each patient, and why those scores are important to determine how to create the plan of care and the treatment goals for each patient individually. And the interdisciplinary team, very important. I want you to know that nurses bring a wealth of information to the interdisciplinary care team meetings. We're with the patients 24/7. So share with the team what's going on with your patient, what they're having an okay time with and things are going well with, and the things that aren't going well. Share those with your team. Incorporate those into your care plan for the patient, and just remember to listen, be compassionate, and be kind, and generous with our patients, they will truly appreciate what you do for them. Thank you for coming.